people here, although we might get a couple more. Thank you everyone for attending our last session for the winter quarter. We're really excited to have everyone here. And we're also excited to have Dr. Matul Kapadia here as well, talking about concussion management, something I am very interested in. I'm super excited for this talk today. So Dr. Kapadia directs the UCSF Pediatric Physical Medicine and Rehabilitation Clinic, and he's a pediatric physiatrist. And he specializes in rehab for infants, children, and adolescents. And he treats a lot of conditions such as brain and spinal cord injuries, rheumatologic disorders, amputations, or limb deficiencies, and so on. He went to the University of Texas for medical school and completed his residencies at Thomas Jefferson University Hospitals. And now he is here. So we're very excited to have him. Thank you for joining us.
Thank you for having me, Ariana. Yeah, it's great to have you guys. I wish we could meet in person, but we'll have to do with Zoom. So yes, I direct the pediatric rehab program here at UCSF. I'm also usually the first line of contact for any medical students that have interest in PM&R as a field. And so any of you that are looking at it, I'm usually helping with the process kind of a little bit in the application process. So I'm sure I'll be hearing more from you. We usually do quite a few talks between myself and Dr. Pasquale about the field, starting from first year medical student and moving along. So, but we'll talk a little bit more about concussions. And we've had a concussion program. I've been at UCSF for about 10 years, and we had started a concussion program, I think about 8 years ago now, that has been a very robust program. And it's really the only program that we have out here in the Bay Area. I don't have any disclosures. So, you know, concussions get a ton of media attention. I'm sure you guys know that. And some of these slides might be a little outdated for what it was, but this was Hillary Clinton. This was Junior Seau and the big settlement that had happened with the NFL now 8 years ago in regards to chronic traumatic encephalopathy. You know, when NFL's going on almost every Sunday, we're hearing about concussions. In Monday nights and Thursday nights now from tackling. This was in the World Cup, now also 8 years ago, but there was a lot of attention on FIFA and their management of concussions, a lot of it negative during the past World Cups as well. This is Steph Curry when he had a concussion a few years ago as well. So something that we see a lot, obviously, and it gets a lot of attention, both positive and negative in regards to how we think about concussions. So generally what I'm going to talk about is the laws behind concussions, some of the epidemiologies. We're going to talk a lot about how we define concussions and the symptoms associated with it. And then we'll briefly talk about the treatment, evaluation and treatment, and some of the chronic sequelae regarding concussions. So I always start off with the case of Zack Lystep, who was one of our kind of landmark cases in terms of how we think about concussions and the laws behind concussions. Particularly for youth sports. So this was now 12 years ago in 2009. Zack Lystep, he was in Washington State. He was 13 years old and he played football. It was during a game, he had a number of kind of head-to-head collisions and looked a little wobbly on the field, but at that time he was determined to be okay to continue playing. He kept playing. By the end of the game, his dad had come to see him and he could barely stand and it kind of collapsed. He ended up going to the local hospital there at the University of Washington, ended up having bilateral craniectomy. So they had to take out both sides of his skull to relieve his pressure. He was on a ventilator for about a week. He was in a coma state for about 3 months and then went through kind of a prolonged recovery stage after that. And so he was a case of, you know, this was before we had a lot of laws or rules guiding how we should manage concussions on the field. This was actually a picture I had taken at our PM&R national conference when I was a resident in Seattle. And Zachary's here, he actually walked onto the stage. That was the first time he had walked publicly with his parents, his physiatrist, and his lawyer actually, because this was a big project in terms of public advocacy.
Dr. Kapadia, I don't know if it's just me, but your mic seems to be going in and out as you're talking, like getting quieter and then louder.
Okay, I'm on my desktop here in the hospital, so it should be okay. Let me know though, please, if that happens. Is it okay now, Ariana?
Yeah, that's better.
Okay, I'll talk a little bit louder. So Zachary's case was a great example of kind of the medical side, the parent side, and kind of the legal side, the advocacy side working towards trying to make some kind of common sense laws. And out of this came what's called the Zack Lystep Law, which started initially in Washington State. And it has four key components. So one is that there's have to be guidelines to educate parents and young athletes about concussions. There's an information sheet that has to be signed by the guardians or parents of the child every season. This is the big one. So there was this principle that was really advocated for: when in doubt, sit them out. So if there's any concern on the sideline about a potential head impact, about a potential concussion, the default was that they should not be returning to the field. So in Zachary's case, when he was wobbly on his feet, he was evaluated. He should not have been allowed to continue playing that game. And the fourth part of that is that they must receive clearance from a licensed healthcare provider trained in concussions, and that there's some ambiguity about what a licensed healthcare provider is in terms of clearance for returning to the field. But this was the initial Zack Lystep Law that started in Washington State. Between 2009 and 2014, all 50 states passed a similar law that had basically the same four principles. In California, it passed 10 years ago in 2011, and it basically has the same four principles that were in the initial law in Washington State. So how common are concussions? Again, this is a little bit outdated, but the epidemiology is somewhat similar to what we see now. So in a typical season, this is about 100 kids in a high school football team. We'll have about 5 concussions diagnosed during a season. But when we've actually looked at this in more detail, we think the likelihood is it's closer to 15% or 15% out of these 100 kids that likely are suffering a concussion during a single season. So why are we missing so many concussions? So this was a study back in 2004. About 50% of concussions in high school football players were unreported. And the reasons that were given for players not reporting their symptoms in this study was 2/3 of them said they didn't think their injury was serious enough to need medical attention. 40% said they did not want to leave the game. 36% said they didn't know that their symptoms were consistent with a concussion. And a fifth of the kids did not want to let down their teammates. And that's certainly something that we, especially in the older days, we used to hear a lot from our professional athletes in terms of kind of manning up and getting back on the field and leaving the game as being a sign of weakness in terms of head impact. So what high school sports have the highest incident rates of concussions? This is usually a question I ask in person, but I'll kind of just put the answer out here. So it's probably what you guys are thinking. Football by far and away is the highest rate that we see, about 0.6 rate per 1,000 athletic exposures. Girls soccer is second, and then lacrosse and boys soccer kind of fill in the rest of them in terms of the epidemiology. So what is a brain injury? This is from the brain injury. Ariana, am I sounding okay? I assume that you guys can hear me. Okay.
It is a bit in and out sometimes, but I think especially when you're talking louder, I can still hear all of the words. There's a little bit of fluctuation at times.
I will try to talk louder. So what is a brain injury? It's defined as an external physical force that can produce a diminished or altered state of consciousness, which results in impairment of physical, cognitive, and or emotional functioning, or a disturbance of behavior. And this was the Brain Injury Association of America. And the reason I put that up there is that we just have to know that a concussion is consistent with a mild traumatic brain injury. So that definition is inclusive of what we would call a concussion on the field. Casey, I'm actually going to turn my video off to see if that helps in terms of bandwidth. So what I'm going to do next is I'm going to go through a little bit more details about the definition of concussions. And so every 4 years, there is an international conference on concussions in sport. There's been actually 5 of them now where we get kind of all the experts in sports concussion from around the world together. And these typically happen in Europe. This is a definition that was done from the 3rd International Conference, which was in Zurich, but there's been the most recent one in Berlin, and there have been some revisions, which we will talk about. But I like to kind of go through step by step because it does give a pretty good summation of where we are at in terms of our understanding of concussions. So the first part, it's a blow to the head, neck, or body. So it doesn't necessarily have to be impact to the head. It can be a tackle, for example, to your chest, but it creates a force of movement, particularly rotational force to the brain that results in the symptomatology of a concussion. You typically have a rapid onset of neurological impairment. So the symptoms happen almost instantaneously after the impact. Symptoms are usually short-lived, and we'll talk a little bit more later on about what short-lived means, particularly in terms of kids versus adults. And they resolve spontaneously, but in some cases can be prolonged. Symptoms represent functional or metabolic changes in the central nervous system, not structural injury. So the effect is really happening at the microscopic axonal level in the brain. So part of that is that a CT scan or MRI is not going to show anything abnormal in a concussion. And there's a graded set of clinical syndromes that may or may not include loss of consciousness. Symptom resolution is sequential. So over the period of a number of weeks, we see those symptoms slowly start to resolve. And it's not an instantaneous process. And standard neuroimaging, as I said, like a CT scan or MRI, are going to be normal in the cases of concussions. So this was a question, I had done this talk to a group of community pediatricians, and I kind of had posed this question, so I'll kind of put it out there anyhow. How severe is my concussion? This is a question I get. I was in concussion clinic yesterday. It's a question I get all the time from families and from athletes. So 15-year-old soccer player playing midfielder during a soccer game. She collided head-to-head going for a header, had loss of consciousness for about 2 minutes, does not remember the collision or following events for the next 60 minutes. She's evaluated on the sideline, has headaches, confusion, dizziness, and has episodes of emesis. So how, does anyone want to try to answer how severe you would call this? Mild, moderate, severe?
I would probably call this a severe concussion. I would think anytime you have a loss of consciousness, that would put you out for at least a few weeks.
Thank you, Ted. Anyone else?
I'd agree with the severe. I have a lot of concern with that memory loss for a full 60 minutes. Seems pretty significant.
Thank you. So this is a bit of a trick question. So I'm going to go to the next slide here. So that mild, moderate, and severe. And so this, you guys are right. This is what I learned when I was in medical school about concussions. And there were different scales that we used to use. The CAN-2 one was a very common one. He's a neurosurgeon up on the East Coast, Colorado Medical Society, American Academy of Neurology. And it was based on whether you had loss of consciousness or not, and for how long. It was whether or not you had post-traumatic amnesia, which is that memory loss after the injury. And we would classify concussions based on that. So based on these criteria, certainly the injury would be considered moderate or severe, depending on what scale you're using. But we've actually gotten rid of these scales. And that's partially because as we've studied more and more about concussions, we realized that these scales did not correlate well clinically. So kids that appear to be having a very severe presentation in terms of loss of consciousness, post-traumatic amnesia, and symptomatology were having very mild courses, and vice versa. And so we really don't use those same mild, moderate, severe grades when we talk about concussions because it simply didn't pan out when we've looked at this in kind of large scale studies. So the answer to that question is we don't know. Concussion grading is retrospective, which is obviously not ideal when we're trying to counsel families. And so, like I said, historically, we were using the AAN and the CAN-2 criteria based on post-traumatic amnesia and loss of consciousness at the time of the injury. But we've really removed those as our predictive factors in trying to determine the prognosis of a particular athlete. And really only when an athlete recovers can you then retrospectively say that was a mild course or that was a severe course. And that means we have to be more generalized in our approach clinically towards these athletes than trying to differentiate them. So some other things, this was from the most recent international conference on concussions, as I mentioned, in 2016 in Berlin. And it's the strongest and most predictive factor for slow recovery is the severity of the initial symptoms after an injury. So the constellation of symptoms rather than loss of consciousness or post-traumatic amnesia was the most consistent factor. The development of subacute problems with migraine headaches or depression are likely risk factors for persistent symptoms that last more than the typical month of recovery. And children with pre-injury history of mental health problems, migraine headaches, learning disabilities are at higher risk for persistent symptoms. And in particular in kids, we do a lot of information gathering about what their premorbid history was and premorbid functioning was, because we know that can affect the course of recovery after a head impact. And as I said, children with ADHD or learning disabilities often need more attention to the return to learn and school process. So recovery time after sports concussion in high school athletes, typically what I say is about 85%, 90% of kids are better within 3 to 4 weeks. That's the typical window that has been kind of validated throughout studies in various sports. This was in high school athletes. In adults, it's usually less. It's usually closer to 2 weeks, and kids do take longer than adults to get better. And what's the reason for that? We know that there's structural differences between a developing brain and an adult brain. And there's differences in terms of how the forces and rotational forces and linear forces are translated to a developing brain versus a developed adult brain. So developing brains often take longer to recover than adult brain. And high school athletes have been shown in studies to take longer to recover based on neuropsychological testing in particular compared to college athletes. So there's even a difference between the early adolescent age group and the older adolescent group and that we see in college. So the clinical picture of concussions, I kind of like this grid in terms of the 4 circles of symptoms that we commonly think of with concussions. So there's physical symptoms. Those are things like headaches, nausea, vomiting, blurry vision, feeling off balance. There's cognitive symptoms, which are often feeling slowed down, feeling kind of sluggish. Kids often describe that kind of haziness or foggy feeling, particularly in the school setting. There's emotional symptoms, which can be often kids just describe being more on edge. They're snapping at their parents, they're snapping at their siblings more often. They're more up and down, they're more depressed than their typical emotional state. And then sleep. So this can be kids or adults sleeping more than normal or sleeping less than normal. But often we see difficulty with falling asleep at night, difficulty staying asleep at night, and that can kind of result in this overlap of other symptoms. They get more headaches, they have more sluggishness. In school, they're more emotional because they're not getting good sleep. So there is a lot of overlap in that clinical picture. I'm going to briefly talk about post-concussion syndrome. This can be an entire talk by itself, so I don't want to go into too much depth about it, but I like this definition from Jeff Kutcher from Michigan. Post-concussion syndrome is an ill-defined, ambiguous, poorly understood syndromic cocktail of myriad symptoms and or cognitive deficits, lasting anywhere from a few weeks to a few years, maybe. And that really just points to the fact that there's so much unclarity about post-concussion syndrome. I still say the majority of the kids that I see in my clinic that have come from an emergency department are getting diagnosed with post-concussion syndrome, even though their concussion happened, 2 days ago or 1 day ago. And so there's just a lot of confusion about that terminology, post-concussion syndrome. But generally when we talk about PCS, we talk about up to 15% of concussions. So remember I said about 85% of kids will get better within that 3 to 4 weeks. About 15% will have prolonged symptoms. And we define it as typically symptoms lasting more than 3 weeks or sometimes 4 weeks. Symptoms may be prominent in one area or a blend of all 4 of those areas that we just talked about in terms of symptoms. And it's unusual to develop symptoms that were not present with the original concussion. So if headaches were a prominent symptom early on, we expect headaches to likely be an issue later on. It wouldn't be like there were no headaches acutely and then they developed more of a migraine picture 4 weeks out from their concussion. And the treatment here is really individualized. So we talk about which one of those constellation of symptoms are the predominant factor, and then we approach it that way. So if it's headaches, we want to take a very migrainous headache approach towards management. If it's emotional, we're going to be talking a lot more about psychotherapy and counseling and possibly medications. If it's more sleep, we're going to talk about sleep hygiene and sleep medication. So it depends on what symptoms are the predominant factor, rather than just kind of more generalized approach that we often take acutely for concussion management. I'm going to pause for questions because I've learned that's helpful on Zoom. So I'm going to see if anyone has any questions on what we've talked about before I shift gears a little bit more about the evaluation and treatment.
I do have a quick one, although you may be about to address it, just so I get some clarity. It seemed like you were saying earlier that because we can't determine that severity until we're looking at it in hindsight, although you just said it's unusual to develop symptoms that aren't present with the original condition. Now, as a student PT, I'm thinking in terms of rehab, and is this an evolving condition for post-concussion rehab, or is there some predictable rehab pattern that I can make?
So yeah, that's a great question. I think that came from Keith, and we actually published a paper with my rehab focused physical therapist in our concussion clinic about some of those questions. One of the holy grails of concussion management is trying to find some tools, and there's a lot of research going on about predicting which patient population group will have prolonged symptoms and what kind of category of symptoms may be more prominent. So if we know, for example, this particular athlete is likely to have long-term vestibular balance issues, we can make recommendations kind of early on. And we're trying to start doing that. So we're doing a lot more, for example, vestibular ocular testing, balance testing acutely to try to figure out whether or not that athlete may benefit from more targeted approaches towards, like, for example, physical therapy that may help stave off some of that long-term symptoms. And the similar, if there's a kid that had a history of migraines, for example, pre-injury, we know we need to pay more attention to the migraine and headache piece, because there's a much more likelihood that that kid will have post-concussive syndrome with headaches being a predominant factor. So there are some tools, but we don't have a singular tool right now in our arsenal to be able to say that this particular athlete is likely to have a prolonged course, so we need to make A, B, and C interventions. But that's where a lot of the research is going on in terms of like blood biomarkers, high resolution imaging. There's a lot of different tools that we're looking at in terms of blood flow in the brain and things like that, but nothing has so far become readily available that's shown to be effective. I don't know if I answered your question, Keith, but
You did. That was excellent. Thank you.
Okay, I'm going to keep going. We're going to talk a little bit more about the evaluation. So this is kind of what we do on the sideline evaluation. If you're ever watching a professional sports on TV and you see them like in the NFL, they go in that tent. This is usually what they're doing. This is a test called the STAT. And we're now on the 5th version of it. I think the one I have posted here is the 3rd version of it, but it includes some symptom evaluation, includes some basic cognitive testing, memory testing, and then it includes a very quick and dirty balance evaluation, orientation kind of questions. And so it's a quick way of that, when in doubt, sit them out. So we're trying to quickly screen anyone that may potentially have a concussion just to get them out of the game for further evaluation. So these are kind of these stat cards that most athletic trainers or people on the sideline are holding in their hands, and this is what they're doing when they're evaluating an athlete on the field. So what do we tell our families or our athletes? So we typically say that first 24 to 48 hours, there can be a evolution of those symptoms. So on the sideline, we want the athletes to be supervised with adult supervision, repeated exams, or checking on them every 10 or so minutes just to make sure that that clinical picture isn't evolving. And what we're really worried about is for subacute kind of bleeds in the brain. Uncommon, but that's the concern that we're really worried about, especially during those first few hours. Is an athlete that looks okay may develop into a different clinical picture over time. Overnight, particularly that first night, we want the parents or an adult to be kind of monitoring them, particularly for, again, that same concern that this is not a concussion. This is something more significant that requires medical attention. So when do we tell people to go to the ER if they're having suddenly worsening headaches? Obviously, if they're having seizures all of a sudden, increased drowsiness, lethargy with their heart to wake up, repeated emesis, and then acute neurological things. If you're seeing slurred speech or seeing weakness or numbness in the arms or legs, those are things that are worrisome for not being a concussion or being something that may require more medical attention. Loss of consciousness, and what I'm talking about here is kind of loss of consciousness down the line. They're not responsive. Or if there's concern on the sideline initially and we want to get kind of an assessment from a medical doctor, that there's a reasons to go to the ER initially. What do you do for a physical exam? I'm not going to go into this in depth, but really you're trying to do a very thorough neurological examination, a very thorough fundoscopic examination. And these are things that you're looking for. You're looking for those red flags that this might be something more than a concussion and require more medical attention. And so anything that you're seeing, if you're obviously seeing upper motor neuron signs, you're seeing acute neurological changes on a physical exam, that's going to warrant more attention. These are things that I do in my clinic, and there's a lot of stress on kind of cognitive imbalance testing because those are often things that can be affected from a concussion. So this is just an example of some of the tools that I would use in my clinic for a cognitive screen when I'm seeing a patient. So orientation, serial 7s, memory testing, trail A1B2s, things like that. Balance testing is also very, very important. As we were just talking about with Keith, it's something that we do kind of on the sideline, but also something we do every single visit. It gives us another way of assessing someone's recovery, and also helps us make decisions about return to play for our athletes. So this is kind of an example of what we would do. So a Romberg tandem gait. I think I have some pictures coming in the next slide. Single foot stance with eyes open and eyes closed. And then tandem stance. So tandem gait and tandem stance, which we'll talk about. Eyes closed is really important. So there's a different part of our brain that manages balance when you don't have the visual input of your eyes being open. It's more that vestibular ocular system that's part of your inner ear that often is affected after a concussion. So doing an objective balance assessment is very helpful. It's a useful tool to kind of objectively assess that motor domain of neurological functioning, and something that should be done routinely when you're talking about concussion evaluation. So this is kind of a test called the balance error scoring system, or in short, we always call it the BEST testing. This is what happens typically when you come to a concussion clinic. This is being done on a balance board, as you can see. So that's its regular stance with eyes closed. This is a picture of single leg stance on the ground, and then we also do it on the balance board with eyes open and eyes closed. And this is an example of tandem stance. And tandem stance is usually your strong leg. So the leg that most of our athletes would prefer to kick a ball with will be in front of the other leg. And then we ask again with eyes open and then eyes closed. And what you're measuring is not just loss of balance, but you're measuring sway. So the amount of corrections that athlete has to do to maintain that center of gravity or that balance. So the amount of movement that they're doing to stay centered. This is a tool that we've been using in our concussion clinic for the last 4 or 5 years. It uses the accelerometer of your iPhone or a smartphone to measure what we call sway. The test is called sway. So basically what they do is they hold the device on their chest, and then they do the same positioning. So tandem stance, single leg stance, and the phone itself measures how much correction that they're doing or how much movement they're doing to maintain their balance, and it kind of grades it a score. So it's another tool to kind of give an objective tool in terms of where that athlete is in their recovery. The SCAT-5 we talked about, we use this both on the sideline, but we also use this as a tool in our concussion clinic to evaluate symptoms and also evaluate balance and cognitive functioning, and be able to monitor changes in that over time as we're following an athlete after a concussion. Neuropsych testing is something that is really, really important part of the decision about return to play. So there's a lot of different types of neuropsychological testing. Impact, Cogsport, Headminder. Impact is by far and away the most common test that's done. It's the test that we use in our clinic. And for example, in San Francisco, all of our SFUSD schools, high school schools do baseline impact testing, which means they do the testing pre-season. So you have kind of a baseline to look at if they get injured during the season. It monitors recovery and guide to re-entry. It screens for tendency to minimize or maximize symptoms. And again, it's an opportunity to assess both cognitive and emotional status of that patient. Often cognitive recovery, which is more the academic side of things about getting back in school, differs from the clinical symptoms. What I mean is someone can have their headaches improve, but still feel kind of sluggish or feel slowed or have difficulties with memory, or vice versa. So it has to be something that we look a little bit separately in terms of getting our kids back into school. And so the assessment of cognitive function should be an important component in any return to play protocol. But the caveat to that is that, and when we see this being done in a lot of different places, you shouldn't use that singular test in isolation to make decisions about whether or not an athlete should be cleared for getting back on the field or not. It has to be, it's an important tool, but it's never been validated as a singular tool to make that decision, which unfortunately we do see a lot of centers using because it is a test that's pretty readily available and easy to do. So it should be seen as an aid to the clinical decision-making process. We don't have a singular tool in our arsenal to be able to evaluate, to diagnose a concussion or diagnose where someone's at in their recovery for a concussion. You know, you break your bone, I can give you an x-ray, I can tell you it's broken. I can also take an x-ray to tell you when you've recovered. We don't have that, so we have to look at a lot of different tools together to really determine where someone is at in their recovery course. And so neuropsych testing is a component in that piece of information. Neuroimaging, we talked about this a little bit earlier. So routine imaging, CT scans or MRI brains really don't contribute much to the concussion evaluation. We use those imaging if we're worried about something more severe going on, whether we're worried about a bleed or a structural lesion that may be causing symptoms. Fortunately, this has moved away. When we started this concussion clinic even 8 years ago, you know, almost everyone got CT scan. And there was a lot of concern about missing something in the ER. There was concerns about liability in the ER setting, and there have been some very well done large scale studies that have shifted this, that we know that if you're monitoring the patient in the ER clinically, if they're not having a constellation of A, B, and C symptoms, we don't need to do CT scan. And obviously in kids, we're worried about the radiation exposure and all of that. And so we've really moved away. And so now it's pretty rare that I see kids getting imaging in the acute setting, unless there's something that seems abnormal in their presentation. So the treatment, I always start with this analogy. This is an analogy I really like and I use all the time, a cast for a broken bone, right? So most of our athletes are familiar with it or know someone on their team that's had a broken bone. And we talk about how that cast is not fixing those bones, it's allowing those bones to kind of fix themselves. And also how that cast, if you decided to kind of tough it out and not wear that cast and kept playing your football or soccer or lacrosse or whatever it might be, your bones won't heal, but also your body has mechanisms of communicating that it's being asked to do too much, and that's by causing pain. And so our brain kind of works a lot of the same way. So we have to be able to put our brains in the best position to kind of heal themselves. And if you ask too much of your brain in the recovery process, it's also going to communicate that to you by causing you to have headaches, feeling nauseous, feeling confused, feeling irritable, all those different things that we talked about earlier. So cognitive rest is a big piece of this. And we talk a lot about school and the initial stages, physical rest, which means taking a break from your sports. Medications we often use for symptom management, but I always start with that kind of, we're not treating a concussion with a pill, we're treating the symptoms of a concussion. And if you use that same analogy, you can take pain medicine for your broken bone, but unless you keep that cast on and allow those bones to heal, you're not going to get better. And it's kind of the same with our brain. Obviously no driving or alcohol in the acute phase. Another good analogy is kind of thinking about what happens if your car's low on gas or low on fuel, right? It's going to be making all these noises. It's going to be smoking. It's the symptoms that we think of a concussion in your body, just that your brain doesn't have the fuel that it needs after these initial presentations. And so the treatment is really to allow your body to refuel. So allowing those brain cells the opportunity to recover from their injury. And that means taking a break from some activities that can be very demanding on that brain that's lacking in fuel. I always talk about briefly about supplements. We're in the Bay Area. These are questions that come up all the time. Not just supplements, but I've had patients buy hyperbaric oxygen chambers, and I've had patients do kind of almost anything you can imagine in the context of a concussion. Omega-3 fatty acids are probably the best example of something that has shown some evidence of potentially being protective, but right now that's only been shown in mice, which is why I have a picture of a mouse there, and hasn't correlated yet to human studies. But you look online, you can see almost anything that's marketed as a protective device. This is called recovery water, something you can buy on Amazon that's endorsed by Russell Wilson, but there's a million different products like that, and it just creates a lot of confusion. Right now, there's simply, as this is from the FDA, there's simply no scientific evidence to support the use of any real supplement for the prevention of concussions or the reduction of post-concussion symptoms that would allow athletes to return to play sooner. When I initially see kids in the clinic, I don't even talk about sports. Everything is about feeling better, and then the emphasis is on school because we don't talk about the fun stuff or the sports until our kids are fully back into school. And so we have a lot of attention focused on that. If the athlete's well enough to play sports or play video games or text and do social media, then they're definitely well enough to attend school full time and to take tests and homework. And so there's a lot of attention, a lot of focus. I do a lot of communication with our schools supporting that process and write very detailed letters about that process, which is extra challenging right now with most of our kids doing distance learning, which is very screen-based. And so, for example, I had a kid yesterday that was a football injury that's doing 14 hours a day on Zoom and on his computer to do schoolwork. And so you have to be a lot more creative about what we can do, particularly right now with the pandemic, in terms of trying to get off those screens and get better to allow return to school fully. This is kind of an example from that last international conference in Berlin of a kind of a typical progression. So doing activities at home that are academic school activities, returning part-time to school, full-time, and then transitioning to a more normal school load. So it's kind of a stepwise progression, similar to how we talk about returning to our sports. can I play in next week's game, right? This is a question I had that asked to me 3 times yesterday. And the part of the confusion is, when you watch Sports Center or you watch sports on TV, right? We hear this #1 sports cliche. We're taking it day by day, which is true for maybe an ankle sprain. It's not true for concussion. We talked about how there's a sequential recovery in terms of symptoms. We talked about how it typically takes weeks. And so the response of it's day by day doesn't make a lot of sense with how we know the recovery from a concussion happens. But this is what our athletes are hearing on the media. So there is a progression of activities that happens in terms of physical activities. This first addition, the symptom limited activity, that was a change that happened from our most recent conference in 2017. And something that has shown a lot of evidence, and I'll show one of the papers that led to that. But we used to say no physical activities until you're feeling 100% asymptomatic. As we've studied this more and more, we actually have learned that that's not true. That doing some symptom limited activity, which means going for a walk, going for a jog, doing an elliptical, going swimming, as long as it's not causing symptoms, is actually helpful. It can actually decrease the course of recovery from a concussion, particularly for athletes that are used to being very physically active. So taking that very physically active and doing nothing for a long period of time can actually be more detrimental and cause a longer term course of recovery. And then we go through these steps, which are these kind of 5 steps of recovery. Light aerobic activity, sport-specific activity, which is a lot more stop and go, running drills, those types of things, non-contact practice, which would be, for example, basketball, shooting, layup drills, passing drills, those types of things. We need clearance before we get to contact activity. And so that's that step, that kind of red box there is an important one where we do some additional testing. And we want to be certain that our athletes are recovered before putting them in harm's way, so to speak, where they're putting pads on and tackling, for example, in football. So again, I kind of highlight that symptom limited activity, which was the change. This was kind of the first big study that led to that change. And this has been replicated in a number of different studies since then. But this was published back in 2015 in pediatrics. They took 100 youth patients that were coming into an ER, and they were randomized to an intervention group where they were told to do 5 days of strict rest, in a control group, which was told to do 1 to 2 days of rest and then slowly resuming their physical activities. And then they were evaluated at 3 days and 10 days post-injury. And they saw that there was no difference in cognitive or balance outcomes. And in fact, the intervention group, so the group that did no physical activities, did slightly worse on many of those measurements. And after 10 days, the strict rest group had significantly more symptoms than the group that was doing physical activities after 1 to 2 days of rest. And this has been, as I said, replicated in a number of other studies, and it has led to that kind of change. And certainly my clinical approach has changed since then. This was another study back in JAMA where they looked at college football players in terms of premature return to play. So there was 2,900 college athletes from 25 large colleges all over the United States that had a history of concussion. And what they showed was that if you had a history of more than 3 concussions, you were 3 times more likely to sustain a concussion than a player without that history. And then there was just a significant risk within that same season. So 1 in 15 of the players with a concussion had a repeat concussion in the same season. And 3/4 of those occurred within 7 days of that first injury, and 92% of them occurred within 11 days of that first injury. Basically just showing that a history of concussions is associated with a significantly increased risk of getting another concussion over a short period of time, and also a prolonged recovery from later concussions. So how many concussions is too many? Another common question I get from primary care doctors and from athletes. And the answer is there's no set answer for this. You really have to individualize that decision for that particular athlete. So we do look at concussion history, the number of injuries, how much force, how frequently those injuries have occurred, particularly how quickly they've been happening on top of each other. So there's a difference between having 3 concussions over 5 years, 3 concussions over 5 months. The severity and duration of symptoms and age. And we're definitely more conservative in our younger athletes than we are in our older athletes in terms of the potential for long-term issues. You also have to weigh that importance of that sport for that athlete and what role that sport plays for that particular individual. I'm not going to go through this in depth, but this was a good publication a few years ago in neurology, kind of looking at that. How do we think about retiring someone from their sports? And kind of these 3 circles. One was if you're having imaging changes, right? Something structural differences in the brain or a good reason to back out of playing your contact sports. Are you concerned about the symptoms significantly, cognitive impairment, school functioning, to consider recommending retirement? And then you really have to do that individual weighing of that athlete, about how important their sport is to them. What are the career aspirations of that athlete? How much do we think that these constellation of concussions may impact their life, quality of life, those types of things? And so it's kind of a weighing factor. I for the most part, I can probably count on a handful on how many athletes I've had to take out of their sport permanently. But again, this is a lot based on proper management, making sure our athletes are fully recovered before allowing them to go back in kind of harm's way. So injury prevention, another common question. So right now, there's no good clinical evidence that currently available protective equipment, no matter how much is marketed on social media and on the internet, will prevent concussions. What has shown some initial positive results, again, this is from that most recent international conference, helmets in skiing and snowboarding decrease overall TBI rates. Well, you wear helmets not for prevention of concussions, but for preventing more significant brain injuries, right? If you think about helmets, they're preventing intracranial trauma, they're preventing bleeds essentially, but they don't prevent the rotational forces that happen with the brain that causes concussions. Mouth guards did show some non-significant trend towards a protective effect in hockey in particular. There was strong evidence towards disallowing body checking, which has now happened in youth hockey, based on the studies that have shown that in terms of decreasing concussions in hockey. And there's minimal evidence to support individual injury prevention strategies. So actually teaching ways to prevent head impact in sports as helping. There is one surgery for concussions. I put this as a joke in our techectomy, because this is something that there's just so much information about concussions. It can be very hard for a parent or an athlete when they're looking at things online about trying to figure out what's good and what's bad, what works, what doesn't work. And so much of this information is being fed by some of our professional athletes. So I try to ground myself on what we know and what is shown clinically to be effective, and trying to kind of stain for some of those things and telling our families the same thing. Concussions are still very misunderstood. This was now 14 years ago in the New England Journal of Medicine. They define concussion refers to an immediate and transient loss of consciousness accompanied by a brief period of amnesia after a blow to the head. Every single one of those points has now been proven to be wrong. So it doesn't require loss of consciousness, it doesn't require amnesia, and it doesn't require a blow to the head. But this was what was being defined in our medical journals about concussions not that long ago. Most people still think that the symptoms of a concussion will only last a few days. Goes back to that kind of anecdote of we'll take it day by day. It's an invisible injury. There's no physical, there's not an x-ray that I can show for the injury. It's poorly understood even by healthcare workers and teachers, for example, that use that term post-concussion syndrome for an acute concussion. And there's still that expectation from others to get back in the game, letting down your teammates, that type of thing. That fortunately has improved some with some of these rule changes. So if you're going to kind of go find one article to read about it, I would encourage you guys to read the most recent consensus statement on concussions, which does a very good summation of where we're at in terms of literature in our management for concussions. There's just some other sites on my slides here. My pearls have a high index of suspicion of concussions, particularly if you're evaluating an athlete acutely. When in doubt, sit them out. We talk a lot about that, but that's probably the most important takeaway that I would want anyone to get from my talks here. Symptoms usually resolve in 1 or 2 weeks for adults, longer in kids. We talked about 3 or 4 weeks as being the typical recovery course for 85 to 90% of our kids. The treatment is kind of letting the tank refuel, so for cognitive and physical rest. We focus on a stepwise return to school first, and then a stepwise return back to their sports. And we're much more conservative in kids than adults. And I'm going to open up the questions. I know that Casey and Ariana, you wanted me to talk a little bit about the day in the life, which I can do after we talk about concussions some.
Thank you so much. And I remember also that you said that you might need to step out early. So just let us know your timing for that as well.
Yeah, I'll probably have to break away at about 12:55. I have a patient at 1, so I got to get over to clinic. But does anyone have any concussion related questions?
I have one concussion related question, and it was about that the relationship between a prior concussion and the increased likelihood of having another if you did have that prior concussion. And do you have studies shown that this is because, like, you know, somebody who gets a concussion the first time, it could be related to the position they're playing or like how aggressive they are or their technique, or is it something about like a neural protective mechanism in the brain?
Great question, Ted. And the answer is we don't absolutely know. We certainly think there are probably some biological factors why, you know, the same hit by two different athletes will cause two different constellation of symptoms. One of the things we know for sure is that premature return to sports is a significant factor. So an athlete that has had a concussion that went back to their sport too early while they were still symptomatic and gets hits again. The way I always describe it to families is it's exponential, not additive. We think that if you had concussions, you've had full recovery, then your risk of getting another concussion or the risk of a more severe course is not any different than someone that's never had a concussion. But if you're still recovering and you get hit again, those things exponentially add up. They make you much more likely to have long-term issues. And that's kind of the worry. I didn't talk a lot about chronic traumatic encephalopathy because I think that's a whole nother conversation, but that's the worry. Like, for example, in football is those repetitive head injuries that are happening. Even if they're subconcussive, that means they didn't have any symptoms, but those hits are happening day in and day out. And those add up over time because they haven't had time to recover in between those injuries. Anyone else? I got a thumbs up from Ted. I'll take it. I know I covered a lot of ground, and I know we have a wide spectrum of people listening. So
I think one question I have, I'm always just curious with concussion, and there are a few other examples where I wonder what do you think your perspective as a physiatrist is in terms of concussion treatment, and how might that differ from someone who's trained in neurology or sports medicine via a different route, or primary care? Do you feel like, whether in terms of the training and how that brought you here, or in terms of just like the way you approach it, do you see differences, or do you think it sort of all converges to the same place?
I think there are definitely differences, and I think this has been an evolving process. I don't think physiatrists were the primary concussion doctors many years ago, but I think over time, as concussions have become more well understood in the medical community and has gotten more attention, it became a natural kind of thread to what we do. We're the TBI experts, right? We take care of the full spectrum of brain injuries. And I started with the fact that concussions are a brain injury. And so thinking about a brain injury as more of a functional issue is kind of our area of expertise. That's what we do. I take care of all kids with brain injuries. And so we bring that, I think, in ways that we're talking about, you know, I think there's a tendency from, I don't want to discount other specialties, but there's a tendency to think of things in isolation. So a neurologist or a headache doctor might be thinking just focusing on the headache and might be more inclined to start migraine medications, which I won't typically do initially. A primary care doctor may be focused really on clearance for school and sports. And a primary care doctor has 15, maybe 30 minutes to do this, which is challenging to do. So I do think we're naturally inclined towards the physiology and the functional evaluation of concussion recovery, because that's what we do. That's what our expertise is. And I think that aligns very well with the way concussions are managed in the recovery process. And so I felt very comfortable, probably more than a lot of my neurology colleagues, for example, in terms of the management of these kids in the course of recovery.
Thank you. That's super helpful.
Well, I only have a few minutes, so maybe I'll briefly talk about kind of the day in the life of a pediatric physiatrist. And so I'm a pediatrician, and I did a double boarded residency in pediatrics and in physical medicine or rehabilitation. So I'm both, and I'm board certified in pediatric rehab. So a little bit of a different flavor than an adult physiatrist. We end up being a little bit of a jack of all trades in the pediatric realm. So we do inpatient rehab. I take care of kids that have had significant injuries or brain tumors or surgery, like epilepsy surgery, things like that affected their function, their speech, their cognitive abilities. On the inpatient side of things, we do a lot of outpatient as well. So we take care of those kids. I obviously do a concussion clinic. I'm the director of our spina bifida clinic. So we do a lot of outpatient things. We do a lot of procedures, Botox injections, phenol injections, EMGs, those types of things as well. And then I obviously do a lot of education and research and academic kind of stuff. So we end up being a little bit of everything. I think in the adult realm, it tends to be a little bit more siloed. So there's a tendency, at least in the current PM&R world, to kind of be sports medicine or pain focused or EMG focused or inpatient neuro focused. So there's definitely potential to have more of that. I think in the pediatric realm, we're definitely doing more of that. So my typical day, if I'm on service for inpatient, which I'm not right now, I will be rounding on patients on the inpatient side of things. I would have clinic many days of the week. I'm running to clinic right now where I'm seeing both patients from follow-up from inpatient or I have 2 Botox evaluations today. I have another child that had a bone marrow transplant for this metabolic disease that has had contractures and has been recovering. So I'm evaluating their recovery and whether or not we can intervene better to help with the contractures of her arms and legs. So a wide spectrum of things, I think. And so I like that. It keeps me on my toes. I get to do a little bit of everything I love. I love inpatient medicine. I love concussions and kind of that side of things. And I'm able to kind of find the niche of things that I have interest in and that excite me, which is great. And I love working with kids. And so that's something that really was a good fit for my interest. That's my clip note version, but I'm happy to talk. We do a lot of talks to you guys through the years about the field, the different avenues, and I'm happy to meet or talk to anyone if they have any interest or questions about physiatry as a field. I have a minute or two if anyone has any pressing questions they want to ask about that. I will take that as a no. I answered everything. Casey, I have to run a clinic. You feel free to give people my email if they have any questions or anything like that down the line. I'm happy to chat with them.
Awesome. Thank you so much for your time today, and we'll let you get to clinic, but much appreciated. This was really, really great. Thank you.